Hey podcast listeners, welcome back to another installment of the Brainwaves podcast, a show about neurology and medicine and all the fascinating history that comes with it. I'm your host, Jim Siegler, and this week on the program, just when you think you fixed one organ problem, another one surfaces. Central nervous system complications following organ transplantation. Unfortunately, there's just no way we can get to all this content in a single 20 or 30 minute episode, so we've divided the subject into two programs. First, the neuroinfectious complications of transplant, where I'll be chatting with one of the neurology residents who works with me at Penn about some of these atypical infections, Linda Jo.
Hi, my name's Linda Jo. I'm one of the fourth-year neurology residents at UPenn. I'm going to neurocritical care at Brigham and MGH next year.
And in the second episode, I'm going to talk with a neurointensivist at WashU about how he manages the non-infectious complications. If you think this is not really your thing, or if you feel like it's something that you're not likely to come across in your own practice, I think you should reconsider. More and more patients are receiving organ transplants every year, and our immune therapies are continuing to improve, and continuing to increase the longevity of these patients' lives. And together, more patients are going to be at risk of complications. And, when you think about it, it's a topic that only we as doctors are to blame. Almost none of these complications would exist were it not for us trying to solve one problem. By doing so, we've created another. Stay with us. So I'll start this episode with an opening fact that infectious complications following organ transplantation, they typically manifest 1 to 6 months or longer after the transplant, unless there's something systemic, as in a complication of the transplant, like they've got a UTI or an aspiration pneumonia. And acutely in the first month, when I think about infectious complications of transplantation, opportunistic infections don't usually jump to my mind.
Right. So early on, these mental status changes should make you think of other conditions, which will come up in the next episode with Dr. Dhar. But to give the listeners a sense of the importance of neuroinfectious complications, in the adult population, the majority of CNS infections occur in the relatively small number of patients with cancer or among patients who are immunosuppressed. While kidneys outnumber all other solid organs combined as far as which ones are transplanted nowadays, the organs that carry the greatest risk of opportunistic infection are heart, lung, and intestines. Dr. Amy Pruitt, one of our master clinicians, who you've had on the show before to talk about glial tumors, wrote a great paper in this in Continuum last October, and the listeners can find this reference in the show notes. In fact, 1/4 of all bacterial infections of the nervous system are due to neurosurgical intervention for patients with primary CNS tumors.
And while you can mentally categorize the various types of neurologic infections by the risk factors the patient has, like instrumentation, for example,
which makes me think of Staph aureus or other gram-positive skin flora.
Or uncontrolled diabetes.
That makes me think of mucor endocardia.
And what about HIV?
So if it's uncontrolled, I'm thinking about toxoplasmosis, cryptococcomas, and EBV-associated primary CNS lymphoma.
Exactly. So these are some of the easy buzzwords that you should commit to memory when dealing with this particular class of patients. But instead of just giving our listeners a series of word associations, which you can get from any kind of review textbook, let's get into the real meat of the show, starting with the exam features. So Linda, what are some of the key clinical characteristics that you think of when evaluating a patient after they've had an organ transplant?
Well, I think it's important to know that in these patients who lack a normal immune system, they may not exhibit the same classic symptoms of CNS infection as you or me. They may not be able to mount a fever, they may not have a headache or meningeal signs if they are on steroids, but still, generally speaking, there are some findings which can help you. An acute and focal neurologic exam may suggest hemorrhage from an infectious aneurysm, or it can be a hemorrhagic abscess like we see in aspergillosis. Or it could be related to infarction due to endocarditis or VZV vasculitis. Now, contrast this with a progressively worsening but still focal exam, which may indicate a growing fungal or bacterial process, or even something more atypical, like JC virus-associated PML or EBV-associated primary CNS lymphoma. In a patient who comes in with nausea, vomiting, and has a positional headache, those are some of the only signs you may get for an immunocompromised patient with meningitis. A decline in mental status with cranial nerve abnormalities might suggest a posterior fossa process, something like Listeria rhomboencephalitis.
If we move down the spinal cord, a subacute myelopathy could be related to a number of different things, usually viruses. With predominant anterior horn involvement, this is what we see in poliomyelitis, intravirus, Howison virus, rabies, and West Nile. And West Nile can also cause a radiculitis.
Then there is VZV, which can occur following a shingles rash or without the rash, the zoster sin herpete. Is that how you say it?
I don't know. I think, zoster sin herpete. I don't know.
And lastly, CMV can cause a myelopathy, particularly in patients with lymphopenia.
And while the exam is important, you've got to rely on that microdata. These patients can have very unusual opportunistic infections, and so you'll have to make the laboratory diagnosis most of the time, rather than just a clinical or radiographic diagnosis. So Linda, what does the CSF typically show in these patients?
Well, that's an interesting point because the fluid in these patients can be extremely bland and nonspecific. Protein and cell counts may be normal, even in some cases of opportunistic encephalitis, but some features may clue you in.
Like high red blood cell counts, which make me think about HSV, and hypoglycemia, which should make you think about TB or bacterial meningitis or leptomeningeal carcinomatosis.
Exactly. But before we even proceed with the LP for an immunocompromised patient, regardless of symptoms, experts recommend getting at minimum a head CT before the LP. This is precisely because the patient's symptoms may be so inaccurately representative of the severity of the CNS disease. A mild headache in an AIDS patient could be related to a massive CNS lymphoma.
All right, so maybe let's talk about the imaging next. And because these patients don't have a normal immune response, they don't have the same inflammatory defense system that's engaged, their imaging won't be something like what you'd expect in somebody who's immunocompetent.
Yeah, and remembering this will help you down the line when interpreting brain imaging. Here are the common pitfalls. Steroid use may attenuate contrast enhancement, so don't count on this. Diffuse pachymeningeal enhancement may occur with intracranial hypotension after a lumbar puncture and may not mean the patient has meningitis. And lastly, cortical flare abnormalities are a nonspecific finding of encephalitis, but they can also be seen with hyperoxia from mechanical ventilation, seizures, hypoxic ischemic encephalopathy, and some patterns of cerebral infarction, or sometimes this cortical rim pattern can be seen in sporadic CJD.
Besides these pitfalls, what else could be telling on MRI?
Well, Jim, you're a stroke guy, so I know you've got a broad differential diagnosis for restricted diffusion. In organ transplant patients, the DWI sequence can be particularly useful when you suspect an abscess, and this will be very bright on DWI and dark on ADC because of the high cellularity of the abscess and viscosity of the pus.
And sometimes metastasis, and certain tumors can also be DWI bright, but I think of this being as less bright than abscesses.
And the pattern of involvement can be helpful. Bitemporal flare changes may indicate HSV1 or HHV6, while bilateral basal ganglia flare changes are seen in West Nile rabies.
Now, you brought up rabies, and I think that we should talk about this for a second because it's really interesting. And listeners out there probably think that we're crazy. I mean, rabies from an organ transplant? But apparently it does happen.
Oh, definitely. We actually had a case of rabies in Philadelphia this past summer, entirely unrelated to an organ transplant. But you're right, it's definitely important to bring up. Usually, the standard workup involves ruling out cancers, systemic bacterial infections, and then only a few viruses.
According to the CDC, these include HIV, HBV, HCV, CMV, and Epstein-Barr virus. No rabies. So, Linda, how important is it to know about rabies?
Well, first of all, rabies is highly fatal, but also incredibly rare. So while it's not helpful to screen all donors for rabies virus, the Organ Procurement Organization, or OPO, and the treating medical team should take the responsibility for reasonably evaluating a patient as to the cause of death before organs are harvested.
And as it turns out, we have missed this in the past. And I don't think that it's the fault of the OPOs or necessarily the fault of the treating team who evaluated and cared for the organ donor. It's just one of those things that happens. And we should be on the lookout for it because it has led to devastating consequences. One of the most horrifying cases that I'm aware of, and this was back in 2004, was the outbreak involving 4 transplanted patients from a single donor in Texas. 1 patient who'd received a liver, 2 who'd received kidneys, and 1 who had a vascular graft. And all 4 of these patients actually died of encephalitis within 50 days of their transplant, each of them due to rabies.
Officials then re-examined the donor's death and determined the donor also died of rabies. Symptoms are varied.
It turns out that the donor had actually been bitten by a bat, and that's what led him to progress into a coma, although he had also had a subarachnoid hemorrhage on imaging, and so that was actually the cause of death. They found out that bat detail way later, after the other 4 patients had died. And you'd think that we would have learned to evaluate or screen for this kind of thing in our organ donors. But this actually wasn't the only instance of rabies transmission from an organ donor since then.
Regarding the death of a Maryland man who became the state's first fatal case of rabies in almost 40 years. According to the CDC, he contracted the disease from a kidney transplant.
An unidentified man received the kidney from a person in Florida in a surgery that was performed at Walter Reed Army Medical.
So in 2013, as you heard from this news clip, another transplant recipient died of rabies.
How can something like this happen?
Well, it's very rare. Rabies can be passed on through...
And although this was 18 months after the transplantation, the organ donor was later autopsied and rabies was isolated from brain tissue.
We talked about rabies extensively in a prior show with Dr. Krista Rickert, so you should check that out if you haven't already. But since we're talking about the imaging here, rabies can cause early bilateral mesial temporal flare abnormalities with eventual involvement of the basal ganglia and the thalamus.
It's very rare, but it is one of those rare conditions we actually don't screen transplanted organs for. Alright, enough about rabies. Let's move on to something else.
So we covered cortical imaging abnormalities and the basal ganglia. So as we progress down towards the brainstem, you can imagine a rhomboencephalitis or a basilar encephalitis, and we see this in listeria meningitis or tuberculosis reactivation. Otherwise, multifocal hemorrhages in the absence of a coagulopathy or DIC may be suggestive of aspergillus abscesses, which is highly angioinvasive, or septic emboli from endocarditis. And PML, which we've discussed several times now on the show, it doesn't have to be progressive and it doesn't have to be multifocal. You can get a small amount of brainstem involvement or see cerebellar peduncle flare signal abnormality, or it could be patchy and supratentorial, but almost never should you see enhancement with it.
Besides the imaging, another way to conceptualize the various infections common to transplant recipients is the timing. How soon after transplantation did the patient develop neurologic symptoms?
Yeah, and like we mentioned before, if it's within the first few days or weeks, it's less likely to be that kind of opportunistic pathogen that we've talked about, and it's more likely to be the toxic effect of a drug, a coagulopathic hemorrhage, press, or seizures. Or the infection may be something more systemic, like a UTI or pneumonia. Or if it was a surgical transplantation, not bone marrow transplantation, then maybe a site infection from the transplant.
So more often, like you said, we really think of opportunistic CNS infections following transplant when the patient is at 1 to 6 months post-op. And pathogens can be transmitted by the donor tissue. For those, we usually think of infections like CMV and EBV, or less commonly adenovirus, West Nile, Coxsackie B4, and HTLV1.
And rabies.
Yeah, in some case rabies. Or the pathogens can be acquired from the hospital, like Candida from peripheral IVs or MRSA. And lastly, the infection could have been acquired latent in the body or acquired after the organ was transplanted. These types of infections tend to occur later down the road, months after the strongest immunosuppressing therapies have been administered, or even years later when the patient is chronically and mildly immunosuppressed.
Right. And in those cases, I think about infections like VZV, which can cause a vasculitis, or a myelitis, or a radiculitis. CMV, which can cause an encephalomyelitis. TB reactivation, which we discussed can cause a basilar encephalitis. EBV-associated post-transplant lymphoproliferative disorders of the CNS, like lymphoma, aspergillosis, toxo, or PML.
And one thing about PML, we should distinguish immunosuppressive therapies from immunomodulatory therapies. Usually we see PML after chronic immunomodulatory therapies like natalizumab and fingolimide for multiple sclerosis, and this is most often after a year or two. It's not typical for most standard immunosuppressive regimens. So like we've already mentioned...
That said, we did discuss a case of PML on the podcast in the past, in which the patient had actually presented 20 years after his treatment for Hodgkin's lymphoma. And although his serum white blood cell counts remained normal, it didn't seem like he was immunocompromised. He was actually lymphopenic, and nobody was aware.
Yeah, that's a little unusual and probably terrible luck.
Yeah. Alright, so what next should we talk about for the podcast?
Well, we've mentioned several of the herpes viruses a few times, but I think we should get into them in more detail. Not just because we think of them a lot in our transplant patients, but also because there are some of the few viruses we can actually treat, and they have a lot of clinical overlap.
And because of the overlap, it's not always so clear that you're seeing one virus or the other. We often test for multiple at once.
Right. So like we've already mentioned, VZV can cause several important syndromes, a myelitis, large vessel vasculitis, or radiculitis, and it can do this in any patient regardless of the transplant, solid organ or hematopoietic stem cells. to confirm CNS involvement, and this part confuses people a lot. The most accurate test is going to be comparing the CSF VZV IgG to serum IgG.
Yeah, and this ratio confirms that the antibodies are synthesized intrathecally.
What happens is, by the time neurologic manifestations occur in VZV, the patient will already have been infected by the varicella virus. It remains latent in the body, and now that the patient's immune system is compromised, it will reactivate. So an IgM won't be all that useful either. A CSF PCR might if you suspect recent exposure and no clear history, but most helpful is the IgG ratio in CSF to the serum. Other than VZV, HSV1 temporal lobe encephalitis is pretty common.
And we test for that using PCR. Dr. John Rosenberg discussed that in more detail back in episode 80, the meningitis that keeps coming back. But in transplant recipients, things may be a little different than the molar-raised meningitis that we covered previously.
So in transplant recipients, they may be so immunosuppressed that the classic temporal lobe enhancement or flare signal change is also suppressed. And even with normal imaging in a transplanted patient, you should always consider HSV1 as a cause of seizures or neurologic decline. Definitely not something you want to miss.
And as I mentioned before, you diagnose it by checking the HSV PCR in the CSF after the first couple of days of symptoms. And if it's been more than that, then you check for the IgM in the CSF a week or so later.
Moving on to the other herpes viruses, let's talk about CMV. Unlike HSV and VZV, CMV is the best treated with ganciclovir and classically manifests as a radiculitis, myelitis, or retinitis, but it can also cause an encephalitis. I think it's important to know that...
So again, VZV and CMV can both cause a myelitis and a radiculitis, and this is some of that overlap we talked about with the herpes family.
Next, HHV6, like HSV1, can cause a limbic encephalitis with seizures. And this is not an uncommon board question because it almost exclusively occurs in transplant patients. Epstein-Barr virus is another good one to know, the virus that causes the kissing disease. In the immunosuppressed, EBV can wreak havoc on the nervous system and can result in PTLD and CNS lymphoma, and it can cause a meningoencephalitis. It's also one of the few viruses organ donors are actually tested for, and most donors, about 95% of them, have EBV.
And I think of the last of the herpes viruses that's worth mentioning is HHV7, which I didn't really know about before the podcast. But Linda, what do you think we need to know about that?
Well, HHV7 is one of the least encountered, but we've talked at length about rabies, so we might as well do this one too. Usually, we think of HHV7 in cases of optic neuritis or transverse myelitis in your transplanted patients, and you test for it using CSF PCR.
And before we finish up the show this week, while we've been talking a lot about the infectious CNS complications of organ transplantation, you shouldn't always be jumping to a patient having VZV vasculitis and somebody who's older who had a kidney transplant and now has a stroke.
Right, you shouldn't just be thinking about CNS lymphoma in all your immunosuppressed patients with ALL.
It's important to always keep a broad differential in these situations. That stroke patient could just have AFib. That homogeneously enhancing mass lesion in the brain could be a benign meningioma.
So bear in mind these atypical pathogens that we've discussed, but don't go into your next case of an immunocompromised organ recipient and think only of these opportunistic infections. As always, keep a broad differential. Think about things you don't want to miss, think about common diagnoses, and then the rare ones that we've talked about today.
And that about does it for the show this week. Thanks for joining us on the Brainwaves podcast. If you learned anything at all, take a moment to rate the program on Apple Podcasts or Stitcher, Google Play, or wherever you get your podcasts. And if you didn't learn something, or you were hoping for more information, let us know by writing us at bweditorialboard@gmail.com, and maybe we'll put together a show in the future that you think would be good to review. The program you heard this week was produced at a Studio 3 in Philadelphia, Pennsylvania, and it was put together by myself, Jim Siegler, and Linda Zhou. Music was courtesy of Jason Shaw, Josh Woodward, and Lee Rosevere. Sound effects by Daniel Simeon and Mike Koenig under a Creative Commons license. I'm Jim Siegler, and I'll talk to you again soon.